Okay, Assalamualaikum, a very good evening to all of you. Ladies and gentlemen, a warm and also cordial welcome to the MedTweetMY professional webinar session. It is an absolute pleasure to have you all here tonight. Our visual stage is graced by a distinguished and highly experienced individual, Datuk Dr. Alzamani, a renowned name in the realm of emergency medicine. He served as a distinguished consultant in emergency medicine at the esteemed Hospital Kuala Lumpur. And notably, he is also the president-elect of the College of Emergency Physicians. Dr. Alzamani's journey is marked by a wealth of experience, particularly in the field of emergency medicine, with a focus on managing sepsis, a critical aspect of emergency care. His insights are nothing short of invaluable. Tonight, we are privileged to delve into this significant topic under his guidance. Without prolonging the anticipation any further, it is my honor to extend a warm invitation to Dr. Alzamani, who will enlighten us with his profound expertise in the upcoming lecture. Ladies and gentlemen, let us give a virtual round of applause as we welcome Dr. Alzamani to take the virtual podium. Datuk?
Bismillahirrahmanirrahim. Thank you, Dr. Iskandar Mirza, for the kind introduction. Assalamualaikum and good evening to all of you out there who's probably tuning in. I think straight away share my screen, and I'm given 1 hour, right, to share this topic. So let me put it up and check whether you could see my slides. Can you see my slides, Iskandar?
Yes, Datuk, can.
Okay, and can you hear me loud and clear?
Yeah, clear.
Okay, so without further ado, I will just continue. It's 8:33 now. So tonight I will be talking on the management of sepsis, and I think this topic is relevant to probably all of us, because sepsis is just so common. You could probably see and relate when you see, like, for example, a 60 years old gentleman with a history of diabetes and hypertension coming to you complaining of cough, green phlegm and fever for 5 days. And upon arrival, the blood pressure was 50 or 80 over 50. The heart rate was tachycardic 121 per minute. The respiratory is 28 tachypneic. The temperature is high, 40 degrees Celsius, and the white cell count is 16. That is like a very clear presentation of someone having, at the very least, sepsis, secondary to community-acquired pneumonia. The only thing waiting is that whether this patient would respond to fluid. If he doesn't, the blood pressure is still low, still less than 100. Then this patient is having septic shock by definition. You probably also see another patient like this lady, a 55 years old lady, so had been bedridden and with a history of end-stage renal failure and CCF at the same time. There is pus coming from the IJC side, the BP is only 90 over 60, also tachycardic, tachypneic, temperatures high, white cell increased. So this patient is also having, again, at least sepsis with central related line sepsis from the HD side. Another person, 44 years old, with diabetes and gangrenous toes, having black-colored right, first, second, third toes with pulse again, presenting with a low blood pressure, tachycardic, tachypneic, high temperature, and white cell, like that. On all these patients, they would be deemed as having septic shock when the inotropic agent has to be started just to maintain a mean arterial pressure at 65 and above. The difference between these three is that number one is quite classic, that you could probably institute the recommendations, which I will talk about after this. But for now, the case number two, the lady has an underlying end-stage renal failure and congestive cardiac failure, for which you have to be careful with fluids. And the last person having the source of sepsis, apart from providing all the management for septic shock, you also have to remove the source. So for tonight, I'll be talking about this managing sepsis. And these are the outline of my presentation. I will just introduce you about the sepsis, what it is, what it does to the body, how to tackle it. And I would mention about this guidance of a surviving sepsis campaign, how it originated, and in that it has become our current recommendations to manage this. We will be talking about sepsis versus septic shock. We talk about the mortality and what we need to do in tackling the sepsis, which would include killing the culprit, optimizing the oxygen, preserving the macro circulation, preserving the micro circulation, fixing the complications of the sepsis and septic shock, possibly adding some nutrients, removing the source. And along the way, for each component, I will be also talking about the evolving concept, meaning that some of the work in research, which is on the shelf, but it has not come out of the shelf, meaning that the evidence are not strong, very strong yet, but it may be in the future. So this is actually I would say how we would manage sepsis, in that we have to kill the culprit, providing the antibiotics and whatnot. We have to optimize the oxygen that we give, because it matters in someone having sepsis, that all the cells getting those supply of the oxygen, without which the cells would die, would cause organ dysfunction. We shall talk about preserving the macro circulation. What we mean by the macro circulation is that there's enough circulation that could carry all that oxygen, nutrients to the cells. And we talk about the preserving the micro circulation, because it's not enough having enough fluids, enough circulation, but towards the end, the downstream side, we need to have every cell well circulated. We shall also talk about fixing the complications, because those having sepsis and septic shock, they would have a barrage of complications that you have to address. We will talk about, whether nutrient helps, adding some nutrients, because basically what we're talking about, someone having sepsis, is about ensuring the flow of the circulation to the cells that contain nutrients and oxygen in essence. So logically, that would make sense to add some nutrients. And finally, if there is a source of infection, we need to remove it to make our management complete. So basically, this is the summary of my slide. And we can also already go home, or you could already tune off from this talk, because this will be my summary slide. But of course, I will go a bit in depth into what I mean by all this summary of managing sepsis and septic shock. Okay, so as an introduction, when we talk about sepsis, it is a life-threatening organ dysfunction, basically, and it is caused by a dysregulated host response to infection. So the keyword is that there is infection, and then there is a response to the infection, but the keyword of dysregulated, meaning that in responding to kill off that infection, the body may be at its extremes, and that response can also kill you. So it is a life-threatening situation, and it can cause multiple organs to be dysfunctional, and in the end leading to death. And when we talk about septic shock, it's just a subset of this sepsis, for which the infection, the culprit, the organism is in the bloodstream that is causing all this reaction that actually affects the circulation. So because of this affected circulation to the cell, there would be a circulatory, cellular, and metabolic abnormalities. And this can give rise to cell death, and in the end, organ death, and in the end, human death. So both of these, sepsis and septic shock, it's a major, growing global burden. There's actually 49 million cases of sepsis and 11 million sepsis-related deaths worldwide in 2017. And WHO has declared it as a global health priority. And in fact, when a patient is admitted to our hospital, this is a cost of 20% of all costs of death globally. Okay, so this is what we have from infection, meaning there is some sustainable organism in somewhere in the body, but this infection or this organism has gone into the bloodstream, and the bloodstream carries it all over the body. So this is what we call sepsis. And from sepsis, because of the response, apart from the direct effect of the organism, there can be a septic shock from the vessels has become sort of dilated, and also apart from that, there's a fluid leaking into the tissues. So that would lead to septic shock, and from there will be multi-organ dysfunction. So we look like without septic shock, sepsis alone, you would have a 10% mortality. But once you have a septic shock, there will be a 40% of this mortality. And if you have multiple organ dysfunction, there'll be 50% of mortality. So this is what happens. Sepsis is complex. I mean, just look at this slide. The sepsis itself is a pro-inflammatory disease whereby it causes inflammation everywhere. At the same time, in response to the inflammation, there is anti-inflammatory reaction that can be exaggerated. And that response could make things worse in the body, could even worsen the circulation and giving rise to, again, cell dysfunction and cell death. So this is one thing that probably might want to be interested in, because this what is called as glycocalyx. Glycocalyx is actually it is part of the endothelium, whereby it helps to preserve the circulation so that there wouldn't be leakages, and also it helps to modulate any reaction when there is inflammation. So if you look at a river, but at the sides of the river there is this grass, and that grass helps to prevent the water from leaving the river and going into or in other words prevents it from flooding the banks. So it's the same manner. If you look at this is electron photography of glycocalyx. It looks quite like grass, and it lies just like at the edge of the vessels, and that's what it does. It prevents water from going out. But in sepsis, the organism, the infection could destroy this grass or glycocalyx and causing the leakage, and that causes the problem of septic shock. So not just that, from this reaction to the infection, to the sepsis, to the organism in the circulation, you have all these things happening all at the same time. And from the redistribution of the blood flow, the endothelial responding to the movement of the blood cells, there could be congestion, there could be hemorrhage that goes into the interstitium, there could be intravascular pooling with the vessels becoming pelagic or widened, dilated. It could be edema forming. And in fact, at some point, that edema would also disrupt the circulation, the periphery. There will be increased permeability into the interstitial tissues. There could be decreased red cell deformability. The red cell could not go through because of the distorted microcirculation. There can be arteriovenous shunts taking away precious oxygenated blood from the tissue, from the cells. There can be altered microvascular blood flow, vascular resistance, I mentioned about vasoplegia just now. Even the viscosity of the blood is also altered, and sometimes it could be thickened. There would be a disturbance of the red white cell reactions, and there can be a cardiopulmonary pathology. In fact, there could also be disseminated intravascular coagulation. So all this is a trouble at downstream. So to simplify, just think of a river. If you think of the river, you will see that up there is the dam. This is where you get the water. Sometimes you can even have pump, and then this water would flow. Enough water would flow and then gets to the pipes before it reaches your home. But if you have problem, first, not enough water, or not, the pump is not working well, or along the way, the pipes have been leaking, there's no grass, the water will just disappear, then there would not be enough water reaching the pipes. And that is the micro circulation. Just like the bloodstream, whereby you need the blood, you need the fluid, you need the pump, the good working heart, you need the vessels, the riverbanks that has an intact glycocalyx, that has an intact grass at the sides, so that there would be water preserved inside the vessels, that when it gets to your pipes at home, not just that, even the pipe is not blocked. Sepsis itself can cause microthrombus that could cause blockage over there, and that could cause cell death, that could cause organ death, that could cause death in the end. So this is how we tackle it. So first we need to preserve. If this is a blood flow, we need to have the oxygen or oxygenated water, for example, a nutrient, because we're talking about macro circulation. Up there's enough water here, and to have enough water in the river, you need to have enough water that you receive. You need to have a good pump working, and you need to have that this river is preserved in that water will not leak out. This river is enough to contain the water. So that is about having good macro circulation. We also need to kill the culprit. That if you imagine that the organism is as if something that would kill the grass. In this case, this organism will also kill the glycocalyx. The organism could cause the liver to the river to be widened, vasodilated. So we need to kill that culprit by giving antibiotics. We need to preserve the micro circulation by ensuring that the macro circulation is good, but at the same time, we could do some measurements to be certain that the micro circulation level it is well. So apart from that, when there is already sepsis and septicemic shock, there would be complications. So we need to fix the complications. For example, there may be acute kidney injury, there may be transaminitis, there may be sugar affected. So this is, if you look at all this, when you talk about sepsis, it's just like managing a good flowing river, whereby you ensure the micro circulation upstream, so that in the end you'll get a good micro circulation downstream. So when we talk about the management of sepsis, this is Dr. Emmanuel Rivers. So if you old enough and live, at the time of 2001, so Dr. Rivers had introduced early goal-directed therapy, for which he had instituted a certain set of targets to be achieved, or goals to be achieved within stipulated hours for someone who has sepsis and septicemic shock. So following this paper, in fact, he did the first RCT that will only involve about 293 patients, but it showed a remarkable reduction of mortality if they follow this goal-directed therapy. So following that, a year after, the first sepsis guidelines was introduced, and this has become an international surviving sepsis campaign, which is a global initiative to unite all professionals to reduce death from sepsis. And this has become the global standard for sepsis management. And this is revised every 4 years. And the last revision was in 2021. So in other words, it's like giving you a recipe. People can cook, any doctors can cook. But if you follow an early goal-directed therapy, if you follow the Surviving Sepsis Campaign guidelines, it becomes a recipe book. As you just, treat it without specific guidelines. That would be a chart without a recipe. One can be replicated very easily, and the other one, depends on air tangan tukang masak. So the thing is that we want to replicate a success in reducing mortality, and that's what Dr. Rivers did with the Surviving Sepsis Campaign and its guidelines. There has been marked improvement of survival following the use of this goal-directed therapy or this guideline, for which they call it bundle compliance. There were 3 large RCTs that were done a few years ago, and these were called the landmark study, Process, Arise, and Promise. That was done in America, that was done in New Zealand, as well as in the UK, for which they had a large number of participants, which showed there was no difference in terms of outcome for those who followed the guideline and those who followed, just provided standard care of management. So people may be quick to just say, hey, don't follow the campaign guideline, because it doesn't make a difference in terms of mortality. But I think Dr. Rivers had habitualized the standard care, in the sense that even though it is a standard care, it's still a standard care that still follows what the guidelines prescribe. So, in this sense, in this talk, I'll be referring to what the guideline says and the updates of the recommendations and the reason why. First of all, let us look again as to when sepsis is sepsis or when it is a septic shock. So let's look at this. I think a lot of us in the past had learned this is, in the past there were, in the earlier guidelines, sepsis had been categorized into sepsis, severe sepsis, and septic shock. But in the latest guideline, Sepsis 3 is the latest guideline, there's only sepsis and septic shock. There's no more severe sepsis in between. But when you look at the sepsis, when you make the diagnosis of sepsis, first there is an infection, but this is also accompanied by systemic inflammatory response syndrome, or in short, SIRS. So when there is an infection plus SIRS, meaning that the whole body responds to it, this is sepsis. And if you look at this from infection, when you have SIRS, it becomes sepsis. And in worst case scenario, the blood pressure drops, it becomes septic shock, and then death. So this is how we would say someone is having sepsis or not, septic or not. And from what I have grown up with, I always use SIRS to say if someone is having sepsis or not. Without SIRS, it's just infection, but with SIRS, and what is SIRS? It means that if the temperature is either low, less than 36 degrees Celsius, or high, more than 38 degrees Celsius, or the respiratory rate more than 20 per minute, or the PaCO2 less than 32, or the white cell count is less than 4,000 or more than 12,000, or more than 10% bands. But basically, if you have only 2 out of all these criteria, it's SIRS positive. And that's simple enough. And once you have sepsis, to know whether you have septic shock, is that whether you need vasopressor or not. If you need vasopressor, I mean, you start off with fluids first, but fluids by itself doesn't restore the blood pressure. You need vasopressor just to maintain the MAP of 65 and above. And the serum lactate is also 2 or more. That is already a definition of septic shock. So in the Sepsis 2 guideline, in fact, this had been introduced This Q-SOFA, quick sequential organ failure assessment, whereby you look at three things: whether there is hypotension in the sense the systolic blood pressure is less than 100. You look at the altered mental status, meaning that the GCS less than 15. Or you look at the tachypnea in the sense of the respiratory rate more than 22. If you have 2 out of these 3, that already indicate a high risk for someone with sepsis. So there was a bit of a confusion when this guideline came about, whereby they downplayed the importance of SIRS. They uplifted the Q-SOFA in making diagnosis of sepsis. Actually, it meant nothing. It just meant there is a higher risk of mortality when the SOFA score is 2 or more. But in the later guideline, 2021, they have reverted back to SIRS. They found that Q-SOFA is discouraged even as a sole screening tool when we're determining sepsis. In fact, what works better is the National Early Warning Score, or NEWS, for which you have to plot on a graph. Or the easier one is the SIRS. So I love SIRS. So I would go back to SIRS in diagnosing patient as having sepsis. This is an example of news for which, when you circle under all these respiratory rate, oxygen saturation, the need of oxygen supplementation, temperature, systolic blood pressure, heart rate, and level of consciousness, all this will give you a mark whereby usually 7 and above is pretty bad. So when we look at the mortality prediction, when we compare of someone's positive of SIRS, is about, you could see the sensitivity. In fact, SIRS is the highest sensitivity. And Q-SOFA is only 54%. When you use NEWS 7 or more, it's 77%. And the downside of SIRS is just the specificity, but I would hasten to say that if you already know there's a source of infection and SIRS is positive, that is in that group alone, you do away with other causes like trauma, pancreatitis, and whatnot. That is actually improve the specificity towards accuracy of diagnosis of sepsis. Now, okay, let's look again. Remember just now, one of the things that we do is that we're looking at ensuring that there's enough oxygen going into the circulation. Remember the river just now, right? So this is what the guideline, consensus of experts together with the guideline has recommended. You should start with 15 liters per minute per reservoir mass and titrate it for between only 94 to 98%. If you could achieve that, that's good enough. Or if someone having a risk of hypercapnic respiratory failure, just to target it around 88 to 92%, this will be adequate oxygen. And there is a recommendation to use high-flow nasal cannula and for someone with hypoxic respiratory failure. This is beneficial in the sense that it could increase oxygenation, lower respiratory rate, it would reduce the inspiratory effort, improve survival rates also. If you have to intubate the patient, or if you're using non-invasive ventilator, the tidal volume that is recommended is lower, that is 6 mils per kilogram. So you don't even go to 7 or 8. So this is recommended. For this patient, they would have a better mortality rate. There were 2 recent systemic reviews whereby the low tidal volume ventilation has shown much better in terms of mortality rate. So, and also when you use a high tidal volume, what you actually do is that you are increasing the intrathoracic pressure, which in return would impact upon the cardiovascular function by reducing the venous return and following that reducing cardiac output. So that's not good for circulation. Okay, now secondly, we need to kill the culprit, right? So imagine someone coming to your center, you give the oxygen to just hit the target, then it's a sepsis based on the, there's a source of infection, there is a SIRS positive. You want to kill the culprit. So meaning that you want to give the empirical antibiotic quite early. Take the culture, ideally before you start the antibiotic, but We don't want you to delay the antibiotic, but antibiotic can be given within 1 hour. That is the recommended target by the guideline. So you have time to take the blood culture first, urine culture first. So this is some of the culprits: gram-positive, gram-negative. It can even also be fungal for those immunocompromised. So we have to bear in mind of that. These are the main site of infection, the respiratory being the most common, about 43%, followed by the urinary system, about 16%. The abdominal sepsis also, about 14%. Also, the head, meningoencephalitis, and fever of unknown origin at 14%, and other sites at 13%. So basically, you would give an empirical antibiotic that would have a coverage based on your suspicion. So every hour of delay is associated with increase in mortality. I think about 5% more. And the choice of empiric antimicrobial therapy is based on clinical judgment, not on anything else. Not even some had talked about the use of procalcitonin. No, the guideline is against the use of that. Just a clinical judgment. So you should give it within 1 hour. But for patients with a low to moderate risk of sepsis, for which the diagnosis is, still uncertain, you could actually give it a bit delay of within 3 hours. So, and after that, if the antibiotic started, it has to be reevaluated and de-escalated based on the cultural result that you have taken. So this was what I mentioned just now. Procalcitonin is not to be used for to determine, it can be used to differentiate whether it is a bacterial or other inflammatory conditions, but it is mainly used to de-escalate the antibiotics to limit the time used. There are other biomarkers such as presepsin, which is relatively newer, but it's costly, and the lab that could do it are also limited. Okay, now we've done. We are done with that. The killing the culprit. Now we're looking at how to preserve the macro circulation. Remember the river, yeah? So we want to make sure there's enough water upstream flowing. So when we talk about macro circulation, we're talking about first, there's enough fluid, there's enough water, there's enough fluid in the vessels. Number two, we're talking about there is a good pump, and that is the heart. And number three, we're talking about there's a good pipe, which is the vessels. So first, we need to fill up the fluids to make sure there's enough fluid inside. Number two, we have to make sure the pump is working very well, and that is the heart. And number three, we have to look at the vessels, because if the vessels, from the effect of sepsis or septicemic shock causing the vessels to be vasoplegic or to be vasodilated, then we have to give some medications to provide to make it more constricted. So this is actually basically our strategy for macro circulation, to have enough flowing circulation from upstream. So when we're doing macro circulatory assessment, these are the endpoint for which, in terms of the volume, this is what we could do. We could assess it by looking at the central venous pressure. Usually 8 to 12 is pretty good. We can assess it using the ultrasound by looking at the intravenous IVC, inferior vena cava variability, usually at a good size, about 2 cm, and the variability of less than 50% means that the fluid has filled up the tank. The other thing is to use a passive leg rest test, which is dynamic test, for which you actually simulate giving about 250 mL of fluid without actually giving the fluid, because you lift the legs up and then you look whether there's an increase of the cardiac output, that you could look whether you use the echo machine or you use some other machine that could measure that. So there are other things, more expensive machines that could analyze pulse waveform, the contour analysis machines, for which the pulse pressure variation, stroke volume variation, and in fact, for some patients, for example, those after cardiac surgery, they do measure the pulmonary artery and expiratory occlusion measurement. These things can give indication of the EDICASE, whether the infravascular fluid status is preserved, is good or not, the tank has been filled or not. And then you look at the pump in terms of cardiac output, whereby you can look at the echo. When you do echo to measure the cardiac output, it takes a long time. Actually, you could use a surrogate to cardiac output. The stroke volume is a surrogate to cardiac output, but an easier one is the VTI, because when you could put a cursor over the aorta, you could get this measurement on pulse waveform. And you could use something like ASCOM, which is a non-invasive echo-based probe to measure the cardiac output even. And what is missing here is just the pipe, for which the pipe actually, if you look at your cardiac, if you use the echo, you could also look at the difference of the contraction between when it during diastole and systole. If there's a marked difference, the size is also bigger. That would, the contraction as opposed during systole and diastole, big difference, that points towards vasoplasia. And all this, when you have enough fluid, you have enough, you have a certain cardiac output, and the pipes, which is actually in integrity of pipes preserved, you have the mean arterial pressure that gives us the sort of overall pressure that would that would reach to the downstream in the microcirculation. And you could also look at non-invasive or invasive. The invasive is better, but not everyone has it at their own disposal, especially emergency department. But you may find it in ICU very a lot. Now, when you look at mean arterial pressure, so there's a, when looking at the sepsis-related arterial hypotension, we're talking about systolic blood pressure less than 100. And some actually use 90, but if you look at the QSOFA, it is 100. Or some look at the MAP or a systolic blood pressure decrease of more than 40 millimeter mercury. This is in terms of the septic shock definition. But whatever it is, I think it's easier to target the number of 65. If you could reach that 65 and above, that is the borderline of reaching good circulation. Targeting higher MAP is not even useful. It doesn't reduce organ dysfunction. It may improve microvascular perfusion, especially those with having chronic hypertension, for example. Okay, this is a sepsis pump study in 2014 that utilized a higher MAP, and they found that only the subset of chronic hypertension would benefit from it because they will have less renal replacement therapy as an outcome. Okay, so just now we talked about the MAP, the mean arterial pressure in general. Let's step back and look at the fluids. The important component whereby we need to fill the tank up with. So sepsis can cause vasoplasia. Like I said, it could vasodilate the vessels. When it vasodilates, it's just like an expanded tank. When it is expanded, you need to fill up more for an effective circulation. So the other problem that we have in sepsis, the shedding of glycocalyx, which I mentioned just now, which causes leakage. So it leads to distributive shock. So, and these glycocalyx abnormalities also result in endothelial dysfunction. It can be worsened with aggressive treatments. Basically, if you overload a patient, it could further damage the glycocalyx. That is why we just need to give fluid optimally. And in terms of the types of fluid, crystalloid, a balanced crystalloid is preferable because it's more physiological rather than chloride-rich solutions. And colloids is not in favor. In fact, there's been suspended in Europe because it would increase the risk of tubular necrosis and acute kidney injury. Okay, now we talk about amount of fluids to be given. So this is very much debated. In fact, when we look at the guidelines, the recommendation is to give 30 mL per kilo of crystalloids within the first 3 hours. But this guideline is silent about those patients, for example, having end-stage renal failure, congestive cardiac failure with fluid restrictions. So we have to individualize patients. For such patients, it's quite apt to give 3 to 5 mils per kilo per hour, and we assess whether the tank has been filled up. And how we reassess, as I mentioned just now, we can look at the IVC. We can look at whether the tank has been filled up. There's this concept of fluid tolerance and fluid responsiveness. Fluid tolerance in terms of degree, patient can tolerate fluids without organ dysfunction, whereas the fluid responsiveness is the stroke volume increase of at least 10% with fluid volumes of 200 to 500 ml in 10 to 15 minutes. This fluid responsive is actually pretty useful for us to know whether we should give fluid more or not. Remember, we have to fill up the tank with fluid. So if we are able to assess this, then we would be able to safely give fluid to the limit and then just give the maintenance which is appropriate to the patient. So these tests, like passive leg raise test that I mentioned just now, then we look at the stroke volume or the VTI that would increase by 10% from the flat position. That would give rise to fluid tolerance. Another one is looking at the collapsibility index of the inferior vena cava. When it's more than 50%, that is more fluid responsive. So we could consider that. But there is no consensus yet. But in general, experts favor the use of dynamic tool in the sense of a passive leg raise test. That's the best. There was Perner in 2018 recommended you just give boluses of between half to 1 pint of IV crystalloids with continuous monitoring and an early vasopressor. This seems to be accepted by many experts. So that can be also be another way to do it. So if you have a continuous monitoring, the best if you have a machine, advanced machine pass contour analysis that could show you, whether there is increase of stroke volume or not. But if not, you could still use your echo machine at the bedside to see whether there's increase at least of the VTI by 10%. Okay, in terms of albumin, multiple RCTs and meta-analysis showed it did not improve mortality. So don't waste albumin unless you're facing someone who's having a leakage problem, such as dengue patients. We don't routinely give albumin. It doesn't, even if you're rich, it doesn't result in improved mortality. Okay, so this is the intravascular volume. Okay, I mentioned about this already. This is the measurement that you could do just now. If the static measurement, you could use the CVP if you have it inserted, or in some patients who already got the pulmonary artery inserted, for example, post-surgery. But for the dynamic ones, you look at the inferior vena cava variability, because you can just put your ultrasound by the bedside, and you could look at the stroke volume variation or the VTI. In fact, when you put on the screen, you see that it's up and down, the VTI waves. You know that this would be fluid responsive. So this is a passive leg raise test whereby you could actually put patient on trolley and then lift it up for about 60 to 90 seconds, and you measure before and after either the VTI or the stroke volume, or if you have easier machines like ASCOM, you could do that. So this is using the central venous pressure. You target basically for spontaneously breathing patient between 8 to 12, seems to have an adequate fluid. But for mechanically ventilated patient, it's a bit higher, between 12 to 15 millimeter mercury. But it's a bit unreliable. But if you use the IVC, like this IVC on ultrasound, which is collapsed, and it correlates with the CVP actually. So a good size would be a 2 cm and a collapsibility of less than 50%. But if it's more than 50% or less than 2 cm, that means a patient would be fluid responsive. So so how much fluid is, I've mentioned just now, there's no clarity about that, but you have to titrate individually based on patient existing comorbidity. But in general, we want to keep the MAP at 65 or above. So this is the salvage, optimization, stabilization, and de-escalation concept, whereby when patient first come, you are during the salvaging phase that you do give a bit more fluid, but subsequently it needs to be optimized just enough, not too much, and stabilize, and in fact remove the fluids, not to have it too much and restrict the fluid. This is when patients are already admitted in the ward or in the ICU. Okay, after the fluids, just now, we talk about the pipe. Yeah? In terms of the pipe, I've already mentioned just now that sepsis causes vasoplegia. So the loss of vasomotor tone causes vasodilatation and subsequent hypotension. So this is the MAP, 60 to 65 being the threshold for increased risk of morbidity and mortality. And 65 is an important number that you want to target as a minimum. And if you don't reach this with the fluid started, within the first half an hour, you should already start the vasopressor. The first line of vasopressor is noradrenaline. If 65 is a good number, but if the patient is more than 65 years old, then there is this permissive hypotension, whereby 60 to 65 is acceptable for the elderly. And there is no difference in terms of mortality if you give it a little slightly lower for those 65 years and above. So there's no added benefit to give too much to the MAP, except if the patient is having a chronic hypertension. This is the noradrenaline, and basically noradrenaline is the first choice. Not only it's for its effect on the pipes, but also on the for the coronary perfusion. So it's good for the heart as well. So it improves the coronary perfusion, and when you use it early, it also avoids fluid overload. The second line is vasopressin. If you still fail to get to hit 65 MAP, when you cross 0.5 mic per kilo per minute, you should already start your vasopressin, because too much on noradrenaline would result in too much adrenergic response, too much tachycardia and all that, and that's not good even. So vasopressin you could use as this second line, can be used together with noradrenaline. Meta-analysis has shown that early initiation would result in a shorter ICU length of stay, but can also reduce RRT when you start it early. Yeah, so this is pretty all right. And the third line is adrenaline. So you can add this, especially with a cardiac dysfunction. So actually, it's pretty simple. Just these three vasoactive agents that you need to use: noradrenaline, vasopressin, and you can add adrenaline, especially if there is the cardiac function is not really good. So so this is it. And if you use early vasopressor, you would have a much better outcome for the patient, and do start it early, because every 1 hour delay there is an increased mortality by 5.3%. And in fact, there was also a study that used simultaneous fluids and vasopressor, and there was benefit of less fluid use, lower net fluid balance, shortened duration of hypotension, lower incidence of pulmonary edema, as well as lower arrhythmias. So there's also decreased short-term mortality. So for me, the threshold to start the vasopressors is pretty low when resuscitating patient in septicemic shock. There's also this study of sensor study, a prospective randomized trial looking at the vasopressor in sepsis, for which those presumed septic with maybe less than 65 were randomized to receive noradrenaline straight away, 0.05 mic per kilo per minute. And there was lower mortality in the early noradrenaline group that was started. Okay, now we look at the heart in terms of the use of inotropic agent. Just now it's the pipes. So for the inotropic agent, when we look at the poor cardiac output, with if the cardiac index is less than 2.2 liters per minute per m square, but sometimes you can just look at the contractility of the heart by putting your echo probe, and you could know even without measuring. And dobutamine has been recommended, can be opted to be used, but be careful of the hypotension side effect. But adrenaline is much safer. So this is something to consider apart from adrenaline when there is a cardiac dysfunction. Okay, these are some of the evolving concept that is still, as mentioned just now, on the shelf, but not really has been recommended. There is also the concept of trialing dobutamine, for which they try a limited dose of dobutamine and see whether patient respond or not, especially for cardiac dysfunction. There is an evolving concept of using vasopressin analogs. Just now we talked about vasopressin, but these are the analogs like terlipressin, celepressin, and angiotensin 2. However, the recent studies did not show good result, especially terlipressin has been avoided because of the adverse events. Angiotensin 2 has more possibility of success, but it's still in the research. The use of immunodilators like levosimendan, the calcium sensitizer for heart failure, for example, it doesn't improve morbidity and mortality. So it has taken out and not recommended to be used. And phosphodiesterase 3 drugs like milrinone and enoxaparin also has experimental benefit, but there's scarce clinical evidence, so it's also not recommended. Dexmedetomidine also it attenuates sympathetic response, but outcomes not really strong yet. Esmolol is another experimental drugs with favorable effects on the heart rate and some inflammatory benefits, but again, it is still in research. Methylene blue also has been, on the shelf because it reduces nitric oxide, and there's some small size studies, but there's conflicting results. This is some of the evolving concepts as far as the heart is concerned. So this is about again the pump issue. Most sepsis have a warm shock, but some with a cold shock with a poor periphery perfusion. So when there's low cardiac output presenting with cold shock, it's associated with not enough volume and also sepsis-induced cardiac dysfunction, because the sepsis itself can affect the heart, causing it to have a septic cardiomyopathy. And this is a late phase of septic shock. So if you treat the sepsis, the cardiac function will improve. So the echo is very useful because you could measure the VTI as mentioned just now, very quite fast. But this is pulse wave contour analysis devices, which are expensive. But if you have it, it is really nice to have because it's ongoing continuous monitoring. You can use ASCOM as well, that could measure the cardiac output, the vascular resistance, and other systems like NICOM and invasive cardiac output monitoring devices like pulmonary artery catheter, but this is usually in cardiothoracic surgery ICUs. So these are some of the evolving concepts. I'm not going to go too much, but enough suffice to mention that is in the works, like diastolic shock index, this VA coupling, vasomotor tone. All these are being used in terms of measuring the effect of the vasomotor. This is another one like PPV, SVV, EDIN. All these are evolving concepts, but some are already incorporated in the pulse wave contour analysis machines. VA ECMO also, but in systemic review and meta-analysis may benefit patients with very low LVEF, but there's lack of clinical evidence, so there's no general recommendation for this, and individualization is needed. Okay, now we go to the microcirculation because our goal is to preserve the microcirculation. And when we talk about microcirculation, basically we could measure the by looking at the central venous and arterial CO2 difference, meaning that you take it from the superior vena cava, from the central line, you take the blood gas there, and you take the blood gas at the arterial blood gas, and look at the difference between the central and the arterial. You could know that it's good microcirculation if less than 6. You can look at the capillary refill time, you know it's good if it is less than 3 seconds. You know, you look at the lactate if it comes down less than 2. You look at the central venous saturation, that you would target it between 70 to 90%. And you look at the mixed venous saturation if you have a pulmonary artery catheter, targeting it lower between 60 to 70%. And you look at the urine output. If you have a urine output at 0.5 mils per kilo per hour, that would all this indicate good microcirculation. So this is a microcirculation, like I said, it's like the downstream. And when there was a study that looked at the downstream, whereby they use a lingual camera, and this is what they found, the circulation, the microcirculation. And this is in septic shock. You'll see there's a like troubled circulation in here. And basically, there is some obstruction to the flow in the microcirculation. So there can be like microthrombus and whatnot affecting that. In fact, this camera could see, and in the works, actually, these were the numbers that I mentioned just now, that showed that you have reached good microcirculation. But this is some of the evolving concept whereby they actually institute this camera that could actually look at the microcirculation sublingually. They put it under the tongue, and this could give indicate how good the microcirculation is. And then we look at the lactate, that it is also a diagnostic marker for septic shock when it is more than 2. And it helps to identify occult septic shock as well when the BP is preserved but the lactate is high. But be careful, you can have false positive for liver, especially failure when you use adrenaline, and when you use Ventolin, someone having seizure, someone having glycolysis for starvation or any types of shock can give rise to increased lactate. Okay, the other thing that you could measure is the mixed and central venous saturation that I mentioned just now. The target central venous saturation would be the one that you take from your central line at the superior vena cava. That's the blood, and you expect it to be 70 to 80%. If less than 70% is not good, more than 90% is also not good. This is a balance between supply and demand of oxygen usage. You use a mix. Central venous saturation in the pulmonary artery, especially the levels between 60 to 70%. If you look at this, this I mentioned just now, the CO2 difference between the central line and the arterial, less than 6 means that it's pretty good cardiac output and adequate microcirculatory flow and perfusion. So number 6 is for this central venous arterial CO2 gradient, which indicated in general pretty good. So another thing that you could measure is the capillary refill time. Less than 3 is pretty good. In fact, it's better than the use of lactate. So this is one study, they used that. And in fact, this study, Andromeda shock study, showed that it has a better benefit with than lactate, with less fluid used, less vasopressors, less adrenaline, and better outcome. Yeah, so this is some of the evolving concept. They have a camera that could measure the capillary refill time so that you don't have to look at it. It is processed by AI. And lastly, the urine output. You want to target it more than 0.5 ml per kilo per minute. And this also you have to be careful if you use normal saline too much, can give rise to hypochloremic metabolic acidosis. Okay, now we come to the fixing the complications. We can fix the complications. I'm just going to run quickly in general idea because we don't have much time. But heparin, low molecular weight heparin has been recommended to be used. Because in sepsis or septic shock, there might be it might induce disseminated intravascular coagulation from suppression of fibrinolysis, which would lead to multiple organ failure. So you use this, it would also help. to prevent that, all that like microthrombus and whatnot. Glycemic control is recommended to be targeted between 8 to 10, and infusion, insulin infusion is preferred rather than intermittent subcutaneous ectropics. Proton pump inhibitors has been controversial. It has been shown that it didn't really reduce the risk of bleeding, because what we worry more is the risk of bleeding in sepsis. But at the moment, because of it is cheap, it is very available, this is still recommended to be practiced. Renal replacement therapy, you basically base it on the usual ways of the determining whether the patient needs dialysis or not, from the usual pH, urea level, the acidosis level, and hyperkalemia. Yeah. So, and steroids, there is it is recommended if you use a high dose vasoactive agent, you use a lot of vasopressor, high dose, you need to use the steroids. That's supported by studies. And in terms of sodium bicarb, I just summarize here. You only give it if there is a pH of less 7.1, and also the bicarb is 5 or less. So, and this is beneficial only if patient has AKI stage 2 or 3 or severe acidosis. Okay, this is some of the evolving standard. I'm not going to go too deep into it, just saying that this is one of the things of purifying the blood, but it's still controversial. And lastly is to remove the source, whereby you could use irrigation, surgical removal, operation, amputation, just like the last patient just now, drainage. And in this patient, bronchoscopy, this is before and after, also helps to reduce the source of infection. Okay, how about adding nutrients? So far, the studies showed the role of vitamin not clear. And in the large studies like vitamins and citrus ali, there was no benefit of like the use of vitamin C and thiamine, but there's no harm if you want to give. And some actually advocate to give dextrose and ectopig because they think that it will help in terms of cellular feeding and oxygenation. So come back to the last slide, come back to the first slide, whereby you have all this, and basically how you would manage it would be, basically you would start antimicrobial, antibiotics, fluids, fill up the tank, and you want to hit a 65, and you start to use the noradrenaline, for which if you cross 0.5 mic per kilo per minute, you should start vasopressin as the second line. And if that also fail to achieve that 65, you could add adrenaline, especially if there's a cardiac dysfunction. Sometimes you hit the 65 when you assess the microcirculation, the CRT is prolonged, urine output is not coming out. You might want to actually up or add the vasoactive agent, and sometimes increase a little bit of the MAP. In terms of the mechanical ventilation, you want to reduce it to the tidal volume of 6 ml per kilo. If you do intubate the patient, use steroids if you're using high dose of vasoactives. Heparin, low molecular weight heparin is recommended. Glycemic control is recommended between 8 to 10 millimole per liter with insulin infusion, and proton pump inhibitors and sodium bicarb can be used on case-to-case basis. So sepsis is a life-threatening condition, and it can be done when you actually, this is my summary slide that I've mentioned just now. When you kill the culprit, you could optimize the oxygen well, you preserve the macro circulation, preserve the micro circulation, you fix the complications, probably add a bit of nutrient and remove the source. So if you're able to do this, then you have managed sepsis. So it's the river of life. And with that, I thank you. And I take opportunity here to promote, for all of you to attend the 5th Emergency Medicine Annual Scientific AMAS Conference, which will be held from 28 to 29 August at KLCC Convention Center. It will be really, really exciting, and I really, really recommend, because we've got a lineup of very strong speakers and good topics and contents, and I'm sure you will come out from the conference much wiser if you do come. And please come. And thank you very much.
Okay, thank you very much, Dato' Azhar. Dato, do you think that how much actually participants are joining tonight? I know you can see from the Zoom, but maybe you can't see in the Facebook actually. So far, actually,
I'm not following. I'm sorry, I'm not following.
Huh? Yeah, actually, no, I was asking whether do you know how many participants that we have right now?
I saw it's 354 or on the Zoom.
Yeah, in the Facebook, it's about actually another 50. So almost 400 actually, 400 participants. Such a good turnout. Okay, so so now we go to the Q&A session. So we go for the first one from Hazik. Is starting high HF oxygen therapy is a must, even though the SpO2 not that low. What's the reason behind it? Can we start from nasal prong or face mask first instead?
Yeah, I agree. Actually, from the last paper that I read that was recommended, actually in the SSC guideline, there is no recommendation in terms of the oxygen therapy, other than that you would target it according to the minimum, which is a 94 to 98%. So if when patient comes, actually number one, we look at the clinical presentation. Patient is tachypneic, we could support it. If it is, for example, even 98, but patient is tachypneic, you could still support it with nasal prong, not necessarily a high flow mask. We look at it based on that, and that shall be enough. But if the hypoxic ones, then you could push it up to even high flow nasal cannula to hit the target that you want, which is 94 to 98%.
Okay. Next question from Jazlan. Do you recommend giving antibiotic first in clinic, health clinic before sending patient to the hospital and take blood CNS there? What would be the acceptable delay if so?
Okay. The question is that whether we should start antibiotics in the clinic by itself. Well, seems to be a good idea if the clinic, if the hospital is far. Can be a good idea to start the antibiotic, especially someone is having septic shock, because we want to start it quite right away. Usually, in terms of practicality, if that patient can come to the hospital very quickly, within half an hour, I think things can be processed at the hospital, because it's still within the hour of starting the antibiotics and also the blood CNS. The best is that we take the blood CNS within 1 hour of starting. Before is ideal, but sometimes we don't want to delay. We give the antibiotic, but still take the blood CNS within 1 hour. That is still would yield a result of that. So the question is whether we should give in the clinic. Well, if you have the facility, I have not heard of a GP clinic keeping blood CNS bottles. I think if depends on the distance, but if pretty bad, there's no harm to give the empirical antibiotic if you have.
Okay. So next question for Zafran. Hi, doctor. Can touch a little bit on peds population? How sepsis differ from adult and the management?
That's the thing. Yeah, the sepsis 3 guideline doesn't mention about peds, and in fact, when you manage pediatric population, you realize that people hardly talk about sepsis, septic shock. They talk about broncho pneumonia. They talk about bronchiolitis. But for pediatric population is very much about correcting the deficit of fluid when patient present, in terms of the dehydration percentage, plus the instituting the maintenance, for which you calculated the 2 calculations will start concurrently for the correction, which will be corrected between 12 to 24 hours, but the maintenance will go on hourly, number 1. But number 2, the antibiotics will be instituted just like any infection. Some of them, if they indeed are in septic shock, in the ED setting, they usually start the adrenaline as the first line of the vasoactive agent, because usually in the ED setting it is a peripheral. You don't hardly set a central line in the ED setting. So a low dose of that with the infusion would be what be good enough to start off. That would be fine-tuned later in the ward or in the PITS ICU.
Okay.
In the essence, lebih kurang, tapi it's less vigorous compared to this sepsis, surviving sepsis guideline meant for adults.
Okay. Next question. Can doctor suggest again the amount of fluid boluses in patient with restriction of fluid or in end-stage renal failure patient?
Yeah, I would go with 3 to 5 mils. If you want to be safer, it's 3 mils per kilo per hour, and reassess. So you could actually either you do that and reassess. You could do the PLR. You could give 3 mils per kilo and then repeat PLR. You look at the VTI 10%, give another 3, until the VTI difference, which is a surrogate to stroke volume or cardiac output, is actually less than 10%. So that means it's not going to be fluid responsive anymore. That's the safest. If you don't have, you don't do VTI, you don't do echo, that would be very much macam agak-agak masak lah, cukup garam, cukup air. But you know, you could go clinically by listening to the lungs. There are no crabs, that there's no start to have fluid overload. That's the point that you should stop.
Next question is quite interesting about push dose pressure. Can you tell me more about push dose pressure, especially for those working in KK with no infusion pump? I never done this kind of actually method first previously, because even I work in Sandakan or Tambunan previously also, they still have this infusion pump. But if for those the place that don't have infusion pump, is it okay to do a push dose pressure, or they give it boluses in between timing?
That's a good question. I have not used push boluses before. I'm not experienced in that. But I think you could still, even in peripheral clinic, you could still use the micro chamber, 100 ml, that you could still dilute into this, so that it becomes, you could titrate the amount that goes in, and you know that could be still controlled and mimics an infusion as well. So that can be used by mixing, and what you need to do is to calculate by drip method in terms of how mils per kilo that would correlate into the mic per kilo per minute, because usually there is a graph that you could relate to. So I would propose to go in that manner, because I think it's safer rather than a push bolus.
Okay, okay. So next question is, Datuk, is there a role of fluid resusc in patient with sepsis, increased lactate, but also concurrently having overload symptoms with bivessel lung cavitation and bilateral PD edema? So basically, patient have sepsis, maybe the overloaded is precipitated by the sepsis, whether still gonna give fluid resusc in this kind of patient.
Okay, if I understand the question correctly, lactate is high.
Yeah.
Patient in a state of fluid overload, and
Yes.
you can't give fluid overload, and whether we should give fluid or not, because the lactate is high, right?
Yeah.
Because we're talking just now that lactate is an indicator of sepsis, septic shock, plus it's also an indicator of how good your microcirculation, right? So
Yes.
this is the thing about lactate. This is why it's to interpret lactate, you will have to understand the cause of high lactate can be many things. So some experts have given up on the use of looking at lactate, because you can have liver transaminitis, which could give rise to high lactate. If you use adrenaline just now, yeah, any shocks could give rise to that. So I would forget about it. But number two, I will pay attention to the fluid overload, because I cannot overload the patient. Remember just now, if you overload patient, you would also kill off the glycocalyx. You could worsen the situation, and the patient will be breathless from the fluid overload. So I think you cannot give beyond what is allowed from your fluid responsiveness. If your fluid responsiveness test shows that patients do not going to benefit from fluid overload, don't give more fluids. You just go to the usual targets of your MAP. Make sure if it is not reached, if the fluid is filled up, then it is all about the vasopressor. Even improve the function of the heart with the adrenaline, which when you use also is going to shoot the lactate high up. So forget about lactate in that such situation, but base your targets into most important thing like the MAP being attained, and you could use the CRT rather than lactate, which is better by study by itself.
Okay, thank you very much, Dr. Dato' Azhar. Okay, I think that's it for the question. I would like to thank you sincerely from your presence in today's esteemed webinar. The level of engagement display is truly commendable. I wish to take this opportunity to communicate to the link access for CPD point will be readily available in the chat box. Please be advised that this link will remain active for a brief span of 15 minutes only. I emphasize the importance of ensuring clarity in your email entry, as the issuance of the electronic certificate is an automated process. It is paramount that your email is accurately input, as discrepancies will unfortunately hinder the receipt of the e-certificate. I wish to underscore that the MMA CPD points, the crediting process will transpire in the middle of September directly to your designated account. Lastly, I extend my gratitude to Datuk Dr. Alzar for his profound insight concerning the adept management of sepsis. This evening disclosure indeed resonates as a masterclass, as a knowledge and expertise. Thank you very much, Datuk Alzar, for sharing your insight. I'm very happy with the outcome, and hopefully we can have you again for another session later on.
I would like to reciprocate by thanking Dr. Iskandar Mirza because you are the one who selected the topic, and I'm very much encouraged by the level of participation and the good quality of questions. So, well, I hope everyone benefits and have a good night.
Okay, Datuk. Assalamualaikum.
Waalaikumsalam.